Good afternoon, colleagues and friends. Welcome to our fourth episode of series of Medical Live Zoom webinar on COVID-19. Those who don't know me, I'm Seta Bogosian. I am a GP principal, Surrey Heartland CCG, and I'm also Senior Advisory Clinician on COVID-19 services. I'm also honored to be a chairperson of Armenian Medical Association of Great Britain. Thank you for everyone participating, those sending us questions and joining our webinar today. As we are all now entering into the recovery and stabilization phase of this pandemic, several questions are needed to be addressed. We are honored today to have with us a distinguished two heart specialists and multidisciplinary team of dietitian and investigator cardiologist and a GP. And our moderator will be Professor Nora Pashayan, will introduce them in a few minutes with the great details. Nora is an epidemiologist, consultant in public health medicine, and professor in applied cancer research at UCL. I am now pass the platform to Nora to introduce the speakers and moderate this webinar today. Thank you. Nora, the platform is for you.
Thank you. Thank you, Seta, for organizing this fourth webinar session. Our knowledge of the COVID-19 is evolving, and what we cover today is to the best of our knowledge as of today, 14th June 2020. Now, what we know so far is that COVID-19 is not a simple flu, and it's not a respiratory illness alone. It may well be a vascular disease where there will be a damage of the lining of the blood vessels, leading to clots and affecting multiple organs, including the heart. And that's why the focus of today's webinar is on the heart and the blood vessels. And I'm very pleased to have today with us as panelists, Dr. Rafi Kaprielian, who's a consultant cardiologist at West Middlesex and Hammersmith Hospitals in London, Dr. Sukhjinder Mijher, consultant cardiologist at Chelsea and Westminster Hospitals in London, and an honorary senior clinical lecturer at Imperial College London. Dr. Sergey Barsamyan, who is a cardiology specialty registrar with subspecialty interest in electrophysiology, is based at Oxford University Hospitals. Dr. Barsamyan is also the co-founder of the Armenian Heart Foundation. Very pleased also to have with us Mrs. Arda Halajian, registered dietitian at Central London Community Healthcare NHS Trust. We're going to be joined also by Dr. Christina Bilalian, who's a GP in London at Wandsworth Medical Centre. So today's session will be different from the previous ones. We're going to start the webinar by two short talks that set the context, describe the implications of the COVID-19 and heart and the blood vessels, and also the heart services during the pandemic. And then we will be followed by the panel discussion, taking on the questions that we have received from you so far. But meantime, if you have any questions, please use the chat function of the Zoom, type in your questions, and we'll make sure that we cover all these questions. So I'll start with the first talk. We'll start with Dr. Mijher, please.
Good afternoon, everybody. So thank you very much for your very kind introduction. Very pleased to join you here on this lovely Sunday afternoon and talk about COVID and its interaction with the cardiovascular system. I'm going to share some slides with you now, and I'm just going to bring that onto the screen. So hopefully you can see my slides. So many of you are now very familiar with COVID-19 and the infection and the problems that it causes. Just to summarize, it is a highly infectious virus known as a coronavirus. It's spread by mucosal contact with droplets, and unfortunately our diagnostic screening for it is relatively poor up until recently. And it does cause a highly variable clinical syndrome. Not everybody presents in the same way. And until recently, we generally considered this to be predominantly a lung-based pathology. It does, however, affect a number of other organs, and this schema and graphic here on the left-hand side is purely there as a graphical representation to say that it also affects, in addition to the lungs, the liver, the kidneys, the bowels, and gastrointestinal upset seems to be very common. And as the government has now recognized, anosmia or some kind of impairment of the upper respiratory tract is also very common. And this is on top of the classical symptoms of breathlessness, high fevers, cough, and in many cases, chest discomfort, which appears to be caused by the pneumonic process that goes on within the lungs. That means infection in the lung itself. The screening tests for COVID-19 have not been particularly efficient. PCR-based technology was the principal way forward for quite some time. Chest radiographs, that means a chest X-ray, or a CT scan, however, has a very high diagnostic yield, but it's actually very difficult to get patients in and out through CT scanners, particularly in this current era where we've been worried about maintaining the cleanliness of our hospitals and avoiding the spread. Nonetheless, if a patient has we have some doubt over whether they had COVID-19, a CT scan does reveal the diagnosis fairly promptly. There are a number of different factors that impact the heart. And this schema is deliberately complicated just to say there are lots of different pathways that are going on, but I'm going to summarize them into two main components here. One which involves clotting and the other that involves inflammation. Now, quite how this is being impacted on by the virus is still not clear. And this, we must remember, this is still very fresh in terms of science. And although it feels like a lifetime since we've been in lockdown and since this all started in Wuhan, the reality is science moves slowly and we haven't quite settled this. However, what we do see is these patients have a disturbance of clotting, and we see this with elevated D-dimers and elevated inflammatory markers. And inflammation can occur in multiple organs and can even cause inflammation of the heart itself. This can culminate in either a heart attack, heart failure, or arrhythmia, of which we have seen a whole variety, but most frighteningly, ventricular arrhythmias, which can be life-threatening. What's very clear is the virus causes some form of cardiac damage. And if you look at the case series presented from China and in Italy and Spain, we are now seeing that somewhere between 5 and 25% of patients that have ended up in hospital with COVID-19 have some form of troponin elevation. Troponin is a highly sensitive cardiac enzyme, and basically it indicates that some kind of upset to the heart has happened. Now, we don't call every troponin rise a heart attack, but it does indicate that some form of damage has occurred. If you look through all the different studies, you will see that the presence of troponin elevation is a strong predictor of mortality. This means that patients that have had an elevated troponin level are much more likely to pass away than those patients who do not have that elevation. Also, we see that there is a clear gradation in the size of the troponin leak in relation to the severity of the illness. So the more unwell the patient is, the higher the troponin is. The higher the troponin is, the greater the chance of passing away. And I think that's fairly clear. This is not entirely unique to coronavirus or COVID-19. This also occurs with other viral syndromes, and we see this often with sepsis caused by bacteria and also even by influenza. However, this particular pathway seems to be slightly different from those conditions, in which those are predominantly caused by what we call a type 2 heart attack. That means where the amount of blood supply to the heart is not quite enough for it, causing the enzyme rise. This seems to be causing a different mechanism which we don't fully understand to date. So what do we understand? What have we been seeing? And this is just a brief summary of the kind of patients that we've been seeing in our hospitals. And Rafi and I work at Chelsea and Westminster and at West Middlesex Hospital. And we've seen many patients who've come in with a classical myocardial infarction, and we'll show you a case example of that. But we've also seen cases of myocarditis. This is a frightening and very difficult to treat condition in which there is inflammation of the heart and the enzymes begin to rise very quickly. The patient rapidly develops heart failure of some kind and can cause decompensation. We've also seen episodes of what we consider some form of decompensation of underlying heart condition. Now, what we're rapidly understanding over the last few years is that many patients out there have a dilated cardiomyopathy. This is a natural weakening of the heart muscle, but they don't know about it. And then what happens is they pick up a virus or another illness, they come into hospital and suddenly we discover this underlying problem. And we've certainly seen many different cases of this, and sometimes they can present with an acute heart failure episode. There are also patients developing clots within the heart and clots within the lungs, and we've certainly seen a high level of pulmonary embolism in these patients. A further important factor has been the so-called STEMI mimic, and this was something that raised a great deal of concern within cardiology circles as COVID-19 hit Europe. What we were seeing across the population in Lombardy in Italy, where they had a very high burden of this disease, was that patients were developing ST elevation on their ECG, suggesting that they were having an acute heart attack. However, when you rush these patients into the cardiac catheter lab and perform an invasive procedure, they in fact had normal coronary arteries with no acute blockage. And again, we assume that this is due to some kind of heart inflammation, but we don't have definitive evidence of this. And it's very difficult to discern this based on our usual methods. This obviously leads to a major concern that we may be over-diagnosing myocarditis. And certainly there are now case reports in which patients were diagnosed with myocarditis under the assumption the ST segment change was due to inflammation, when in fact they had blocked heart arteries, and this would have been easily treated if they'd had an invasive procedure. So the overall message from the British Cardiovascular Society and the British Cardiovascular Interventional Society has been that these patients should still be taken to the cardiac catheter lab and have an invasive procedure. We also do rely on echocardiography, and this is just an example here of what an echo looks like. An ultrasound scan of the heart can be very helpful because we can look for areas of weakness within the heart using a simple ultrasound scan, and that can help highlight those patients that have classical heart attack versus those who are having myocarditis. Still not always easy, and one also has to remember that the sonographer is at considerable risk whilst performing these scans because they're right next to the patient and they are highly infectious. A quite remarkable thing happened with COVID-19 when there was the institution of lockdown here in the United Kingdom and in Italy, Spain, and many other countries. We've seen a significant reduction in heart attack presentation. This was really surprising. We were all afraid that our cardiac services would be massively overwhelmed with patients with some form of troponin elevation. But what we actually found were patients were keeping away from the hospital, and the normal NSTEMIs, that means a heart attack where the artery almost blocked but not quite, or a classical STEMI, that means the artery has fully blocked and if not opened has a very high chance of causing the patient to pass away, were simply not coming into hospital. And this is partly driven by the fact that patients were genuinely afraid of coming into hospital and picking up the virus. Globally, we've seen a 30 to 40% reduction in these cases. Some countries like Hong Kong saw a 90% reduction, which is quite remarkable. Now, but this big reduction means that the majority of those heart attacks will still be occurring, but they're not getting treatment. And because of that, there will be patients that have developed heart failure, will have developed holes within the heart from damage, developed clot within the heart that risks stroke, or will be found having passed away in their own homes. And those of you who read the news regularly will have seen increasing cases of this being reported now, with deaths in their own home, and suggests that the reach of the coronavirus is actually much further than just those who are infected. It's also caused mortality by undertreatment. There are lots of reasons for this happening. Some of it is because patients are not ringing emergency services. Some of it is because the standard general practice clinics have not been available for patients and they're not seeing patients in person. Furthermore, if you go to a district general hospital, it's not been easy to transfer patients to the local surgical centre, tertiary centre like in our areas, Hammersmith. It's not straightforward. At the height of the crisis, ambulances were just not available to transfer patients. And so all of these factors together means there is a delay in the diagnosis and a delay in the correct treatment, which will undoubtedly cause harm to patients. On top of all of this, our standard treatments have not been happening as well. So all those patients that have angina, those patients that have ischemia testing, all those patients that have to have elective bypass surgery or stenting will not have been getting their usual treatment in this time, and it is invariable that these patients will have suffered as a consequence. Furthermore, if we just think about those patients at the highest risk, think of those patients with severe aortic stenosis, Those patients have a very high chance of passing away whilst being on waiting lists. There are those patients who've got quite severe blocked up arteries, and there are those patients with significant arrhythmias that need ICDs or ablation procedures. All of these patients needed to be identified by the hospitals very early in the crisis and trying to offer them treatment in a very prompt manner, otherwise they will have suffered as a consequence. So the way we did that, and I'm sure Rafi will expound on this, is that we worked in a 7-day fashion. We tried to offer invasive angiography for every single patient on the same day that they attended. And in those lower risk patients who we felt didn't necessarily need to stay in hospital, we allowed them to go home and then come back in the next day to avoid the amount of time they were exposed to the virus in the hospital. One other thing that I think we've done relatively poorly here in the UK is to learn from countries that suffered greatly from COVID-19, and China was one of those countries. And they actually took a very different approach to the United Kingdom in management of this. Not only did they set up field hospitals, which are quite different from the Nightingale service that was set up here in the UK. The concept of the field hospitals were to remove symptomatic patients from circulation to stop the spread of the virus. They were not really there to provide advanced care. What they also recognized was the higher rate of heart attack in these patients. But in order to reduce spread to physicians and other hospital workers, they made a decision that they would only offer thrombolysis rather than routine angioplasty. Remember, some of these hospitals in China are much more advanced compared to our own. And so this was not them cutting costs, but this was an active decision that they made to make sure their services were available to all. So they were giving clot-busting drugs, which is old-fashioned because predominantly in the United Kingdom, we haven't used this as a mainstay of treatment since 2004. Now, we often look down at clot-busting drugs and thrombolysis, but in fact, if you look at the data, if there is any delay in standard angioplasty, even a delay of 1 hour, then the relative benefit between these two technologies is very, very modest. And in fact, giving a thrombolytic can be life-saving. And that's why we should have that available to us in our hospitals. And we've done that within our own hospital network. We've developed a particular protocol that got a great deal of traction across the country. This was written by a colleague of mine, Dr. Ricardo Petracco, who thought very long and hard about this, and we supported this. And this has meant that those patients who've got significant heart attack and we were not able to offer them angioplasty for whatever reason, we were to give them thrombolysis. So going back to an older form of treatment. So what we've seen overall in this era is a significant reduction in patients coming into the emergency department. We have seen cases of patients dying in their own homes. We've also seen patients not getting the correct treatment they need for their heart attack with delayed presentation and delayed reperfusion. And so as a consequence, we will see late complications of those heart attacks that are occurring out there. So I'm going to stop there now, and I'm going to hand over to Rafi because he's got a very helpful case example of a patient that we treated together.
Okay. Can everyone hear me?
Yes.
Yes. Okay, thank you very much, Suk. That was an excellent presentation outlining some of the challenges, and I'm going to expand a bit on that and also present this one case that we were both involved with in mid-April. So just to recap, in late February, mid-March, there was this great awareness that the pandemic was, it had already had the effect in China. It had arrived, and people went skiing, of course, in northern Italy. And we have very close connections to both China and Italy, interestingly. Our group has had sort of a link with one of the hospitals in Wuhan, of all places. And several of us have spent several weeks there last year on a teaching program. So we were hearing directly from colleagues that we were very great friends with about what the implications were. And similarly, we heard from friends and colleagues directly in Italy who had really hit a very severe situation in Italy where people were in corridors and treatment couldn't be offered. So there was an element of fear and a rapid preparation for this difficult to predict surge in the emergency admissions that were clearly going to hit London. And we had a very short period where we rewrote many of our standard operating protocols, including that protocol that Suk showed for primary angioplasty. And these protocols have been developed over years. We managed to change all of this over the space of about 10 days. And the hospitals geared themselves with rerouting elective work so that ventilators were available for an increased number of patients on an intensive care setting. The West Middlesex had around 3 times the number of intensive care beds than usual. And that meant cessation of all elective work, especially surgical work, which is still ongoing now. And systems were put into place to try and avoid problems with patients who had heart disease and cancer not having their treatment interrupted because of COVID, and that has been a major challenge. In addition to all of this, of course, we wanted to protect our patients who were arriving in the hospital without COVID, but with other emergency conditions. And we had to protect ourselves with the story about the PPE, which was very prominent in the news, and indeed was a challenge across the whole of the service, including our own hospitals. So they've been designated, and there still are designated clean and COVID-19 areas within our hospitals. PPE is still are now much more sorted out, but was a big issue at the time. And we tried to see if we could avoid many of the admissions that we normally have. And we did this by having a hot clinic, which meant a clinic that would contact the patient who'd come to the emergency department and was discharged within 24 hours of their admission to try and sort out their problem remotely. And for patients with acute coronary syndromes, which includes full heart attacks, and these patients with mini heart attacks, which are highly likely to proceed to a full heart attack quite soon in terms of time, we changed our rota so that we were able to try and send people with small heart attacks home with the medications to prevent the heart attack occurring further, and then having them attend on the following morning for their angiogram and their angioplasty if that was necessary. And this meant that the patient was protected from being exposed to a large number of patients who were COVID positive. And we changed our rota so that it was a 7-day service rather than the 5-day service. This all happened within, as I say, a week to 10 days. And outpatients also changed. And it's an ongoing change, which I'd be very interested to hear from the audience if anyone's experienced an outpatient appointment in the health service in the past couple of weeks or in the past 6 weeks. It's a new experience for us and of course for the patients. We are now doing almost all of our outpatients with telephone consultations, which has taken a little bit to get used to. And I just wonder whether this is something here to stay, and it's might be one of the positive spin-offs that COVID-19 has brought. Certainly some feedback is from patients has been, well, it saved them the trip to the hospital, saved them the battle in the car park for finding a spot. They've enjoyed the meeting, and they've had, if they needed tests, they've come in specifically for those tests in a very protected environment to have the tests. So far, a very early feedback has been positive. And anyone else in the audience at the moment wishing to feedback afterwards, it would be very, very interesting to hear. So we were, partly because of this association with COVID and clotting, which Suk has already spoken to, we were expecting a very large increase in the cardiac workload. But in fact, in retrospect, as Suk has already mentioned, COVID-19 has kept a significant proportion of heart attack patients away from hospitals. At least there has been a significant reduction in the number of heart attacks over the past 3 months. And this was looked at. The European Society of Cardiology had a survey which it sent to over 3,000 healthcare practitioners in many countries across the world. and they completed an online survey in late April. And the results of that are on the ESC website. And this is a couple of the slides from that survey. And the first slide here is asking a question: have you perceived a change in the number of people coming to your hospital with STEMI, which is an abbreviation for a heart attack, since the coronavirus outbreak? And you'll see on this graph that the blue bar was the respondents who said that the amount had decreased. And you'll see that across the world, whether in Europe, Asia, South America, etc., around 70% of doctors, of cardiologists, reported an impression that there was a decrease in the number of heart attack patients in their units. And if we try to quantify that, we can see that the purple, the green, and the orange bars were where there was a very large increase from 40% up to 100%. And you can see again, around 2/3 of cardiologists were reporting a 40% or more decrease in the number of STEMI patients. And this has been reflected in our own practice. Both Suk and I are on call for primary angioplasty, in other words, heart attack emergencies at Hammersmith Hospital. And we, as a unit, had a massive reduction in the number of STEMIs over this period. So it was an interesting time for us, in some ways less busy than we'd expected. But we did come across this chap who was who's going to illustrate this change in pathway that Suk mentioned earlier. And he was 66. This isn't actually him, of course. It's just a patient. This is just to focus your mind, a photograph of somebody here. But he had a history of high blood pressure and high cholesterol. And he, in fact, had an angioplasty in the past, but 22 years ago, and he'd been very well since this time. But unfortunately, on the 5th of April, he came to hospital because he had a week's history of shortage of breath and a cough. He hadn't had a fever. And as Suk says, these patients present with a variety of different combinations of symptoms. But importantly, he was found to have a poor oxygen level in his blood, and he required 5 liters of oxygen per minute to reach a saturation of 85%, which is still a very low saturation of oxygen in the blood, and much lower than one we'd normally have, sort of 97, 98 or more just on room air. And this was, of course, a significant reduction. And in fact, he was diagnosed as having COVID very quickly, and he was treated. Now, what was he treated with? He was treated with doxycycline. This is an antibiotic. But of course, there is no treatment for COVID at this current time, or only a very limited number of treatments available, and certainly not hydroxychloroquine, as perhaps the American president might think, because there is no very strong evidence for any treatment. But we have been giving antibiotics because it's quite common when you have a viral infection in the chest to have a secondary infection with bacteria, and the bacteria would respond to doxycycline. He was treated. All of these abbreviations mean that he was treated with supportive oxygen therapy, but not with a ventilator. We found patients who had a ventilator the outcomes have not been very good. We've tried, there's a tendency to try and avoid ventilation, and this is supportive therapies for breathing without actually putting a tube down the patient's throat, but giving oxygen through masks like this, which maintain some extra pressure to help the patient breathe. The patient was also treated with proning. This means that they were turned from front to back for a couple of hours a day. This has been shown to help with recovery and with oxygenation, to allow different parts of the lungs to receive oxygen at different times. And of course, in hospital, he started to spike fevers, and he made a stable but slow progression in his clinical course. He was, if you like, getting slowly better, and it looked like he was going to avoid ventilation, and he was going to be a survivor from his infection. But suddenly one morning, about 4 days after his admission, he developed a severe pain in his chest, which was crushing. He became suddenly very unwell and sweating. He was unable to lie flat and suddenly requiring much more oxygen to maintain the oxygen levels in his blood. Now, we diagnose a heart attack with an ECG, and Suk mentioned the word ST elevation. And these are just two ECGs, this one up here, a normal one, and this one showing an acute heart attack. And the reason we know this is the word ST elevation. What does that mean? That's just a pattern on this ECG. Each one of these squiggles is a heartbeat, the electrical activity of a heartbeat. And in this ECG, which is normal, this segment of the ECG, which is called the ST segment, is in line, if you like, with the baseline of the ECG. And if we compare the same complex in this ECG, you can see the ST segment has risen from the baseline up here. So this is called an ST elevation MI. This strongly correlates if we do an angiogram, which is a picture of the arteries of the heart. This strongly correlates with, and this is the beginning of the artery. This one splits into two. This is the left coronary artery. And you can see that this branch is open and gets smaller and all the way down here. But this one is suddenly blocked off. And when you see ST elevation, when we do an angiogram, we see an artery which is completely blocked. And mechanically, we can suck some clot, which is these little fragments in this small basket, out. And we can, if we remove the clot, the blood flows again in the artery. And the ST segments almost immediately resolve back to normal. You can see even though the clot has been removed and the flow is here, there's still a very severe narrowing in this artery at this point. And then we often put a stent in the artery and the artery is restored. So again, just to explain this, because we're speaking to a general audience, there are two strategies to achieve this opening of an artery. The old strategy, which we haven't used in London for some years, is to use thrombolysis, a drug which dissolves the clot. This is given through a simple cannula in a vein in the arm. It's administered, and within an hour or 3 hours, it dissolves the clot in that artery, and the artery starts to, the blood starts to flow in the artery again. It may leave a residual narrowing, and the patient still may need an angiogram and a stent, but that will only need to be done in the first few months, not as an emergency. The main downside of thrombolysis is the risk of bleeding, because it's not going to be targeted just at the clot in this artery that's blocked off. It's going to be an effect in the whole body. And if there's a weakness in a blood vessel somewhere in the body, it can cause bleeding. And the most dreaded one is a bleeding in the brain, which is almost universally fatal. The alternative strategy is primary angioplasty, which is now what is offered. And this is what we changed during COVID. This is a procedure where we open the artery with a mechanical approach, with an angiogram and various tools, and finally a stent, which holds the artery open, and it restores the flow very quickly. But you can imagine this needs quite a big network approach. It might need a transfer of a patient from one hospital to another if the first hospital doesn't have a cath lab, because not all hospitals do. And it needs to, will have expensive staff costs, so it needs to be set up as a network. The advantage of this is that if the angioplasty can be done efficiently in terms of time, the survival is better than thrombolysis. There's less bleeding than thrombolysis. Almost never get a major bleed, especially in the brain. And it's the standard option throughout the country and throughout much of Europe, apart from if you live in a very, very rural place in the far reaches of Scotland somewhere, where thrombolysis is given to the patient because there's a long transfer time to the cardiac center. And then the patient either undergoes an immediate angioplasty if the ST segments haven't improved, or they are successfully treated by the thrombolysis. So this was our patient. He also had this pattern with the ST elevation. So he had an inferior MI. We knew one of his arteries was blocked, and we came to a discussion. I mean, part of this is we're in new territory. We want to do the best for every patient. One cardiologist on their own may we felt it would be a stronger situation to have discussions with at least 2 cardiologists to make sure that in the context we're doing the best we can for the patient. In him, we had actually Ricardo, I think it was, who wrote the protocol from memory, and Suk and I were on call at West Middlesex. So we had the patient. We could have taken him to the cath lab and done an angioplasty, but he couldn't lie flat. He was his oxygen levels were very low, and going even lower when he lay flat. He would have had to have a tube down and put into his throat. He certainly wasn't safe for transfer to Hammersmith for a procedure there, but the procedure could have been done at West Middlesex. So we decided that the best thing was to invoke the new pathway. And I think actually he was one of the first patients in London to receive thrombolysis. We gave a drug called alteplase, which is one of the thrombolytic agents. There's 3 or 4 to give. We gave various other blood tablets to thin the blood and to stop the stickiness of the platelets in the blood. And within an hour, he felt a little better. And what was great was, if you can remember the previous ECG, the ST segments, as well as him feeling better, had started to come down. Still a little bit elevated, but over the next hour or 2, these became back to normal. The patient felt very much better. He went back to his baseline state, and we had sort of avoided this heart attack. He was pain-free, and we decided, well, we still wouldn't rush in. There's still now going to be a situation where moving him around the hospital was going to put risk to other patients while he moved through corridors, risk to staff while they had to move him, because he was still very much in the infective phase of his COVID. So we waited. We waited actually for about 10 days. He felt better. His COVID has settled. His swabs had become, from memory, they'd become negative. And we did an angiogram, which is this. This is an angiogram of the left coronary artery, which shows that he's got, none of these arteries are normal. They're all a little bit irregular. There's a tight narrowing in this rather small branch, which is not so important. But this is the artery that would have caused the heart attack. We know that because of the position of the abnormalities on his ECG. And we can see 2 things. First of all, we can see a narrowing near the beginning of the artery. And in this view, there's something funny going on around here. And we took a different view. This is the same artery with 2 projections. And you can see actually at that point, there's still a clot in this artery. It's filling up about 2/3 of the artery and indenting it, leaving quite a narrowed vessel, but the flow, enough space for the blood to flow. So we put a stent basically here to deal with this narrowing here, and a short stent here. And the final result was something like this. Well, not something like this, it was this. You can see this looks very satisfactory in both places. And so we stopped. And the patient did well and went home. So we achieved an early reperfusion through a strategy we wouldn't normally use. We stabilized the patient. His oxygenation and clinical state improved. We had a discussion. So it was the case was very discussed in a team setting. And this has been one of the big aspects, I would say, of COVID-19 and hospital medicine. We've started to use things like Zoom, which we're using now. These things were, there was nervousness before COVID-19 because of could these systems be hacked, and they probably could be hacked. But with COVID, there was sudden sort of approval from NHS England to use and discuss patients in using software such as this. And I think that has been a second area where life has improved for hospital care. And I hope that this will be something that we can continue and maybe use as well to help discussions between primary and secondary care and secondary and tertiary care, because communication is always a big challenge in medicine. Anyway, I think that illustrates some of the issues that we've had and a case which went through one of the modified pathways. So I'm going to stop there. And thank you again for your attention, and thank you again, Seta, for the invite and organising this session. And we'll be happy to take some questions.
Right. Thank you very much for the nice talk, nice presentation, which gives us an illustration of the real what you've gone through during the pandemic and how the system has adapted. We have received one question which says, are there any underlying health conditions that can increase the chance of bleeding due to thrombolysis?
Yes, so this is, there are a number of different reasons that we wouldn't give thrombolysis. So in patients that have had previous stroke, that is typically a reason for us not to give a thrombolysis agent. And typically it tends to be a stroke that's happened in recent times. If it happened, 5-10 years ago, it's much lower risk. But if it happened within the last year, then that does elevate the risk considerably. Patients that have had bleeding for any other reason would also make us less likely to give these drugs. For example, some patients have something called varices. These are little extra veins that are grown within the gullet in the food pipe. And in patients who have those, even anything that makes the blood thinner can make those bleed, which can be life-threatening. So these would be two good reasons not to give a blood thinner like thrombolysis. These are key questions that we typically ask before we give those drugs.
Well, thank you. Just I'm conscious of the time, and this is why I will move into the questions we have received. And you have covered some of the points, but very important area, which is the not using of health services during the pandemic. And we've seen from last week's ONS publication of the excess number of deaths in the UK, there were around 58,000 excess deaths, and around 13% of these are not COVID related. So the important question comes up, and we have several of them, how safe it is to go back to hospital. I'll start with Christina. I see Christina is with us, Dr. Bilalian. The first question is how safe it is to go to the GP and therefore to have an EKG.
Hi, we are still running EKGs in the hospital in the clinic setting, in the GP practice. We are obviously maintaining social distancing, so patients are screened and called beforehand to make sure they have no fever, no COVID-like symptoms. In the practice, we are obviously limiting numbers of patients within one go. So there is definitely a gap between one patient and the other. So I think we are doing everything we can to help reduce the chance of infection from COVID in a GP setting.
Okay. And how comfortable do you feel in referring patients to hospital, for example, to have an echocardiogram or other procedures?
We have been referring patients. We haven't stopped it. At the end of the day, we tell a patient, if you are ill, if you are having, let's say, like a heart attack, you are safer being in hospital than being out of hospital, because at the end of the day, you do need to get the care that you need. And patients, I feel that patients have been taking this into account.
Okay, very good. And what about Dr. Niger and Dr. Gabrielian about the cardiac lab? Have you resumed into normal function? Are you doing the angioplasty and stenting as normal, or you're still doing some adaptations?
This is a very tricky question. So we are, Rafi is laughing because we are very, very keen to restart our normal services, because the longer we wait, the greater this list will be, and the longer the delays for patients. The problem has been, for example, at the Hammersmith, they have restarted their elective services, but they've struggled to convince patients to come in. I held a clinic just the other day where I was struggling to convince patients that had meaningful symptoms, high-risk tests, and I was offering them to come in to have a procedure promptly, and they were choosing not to come. And for example, we have an elective list that starts this coming Wednesday at the Hammersmith. 3 patients were offered to come in, only 1 is accepted. So this is a problem.
This has been, again, this is the next round of adaptation to COVID. And the 2 sites we work are a little different. I mean, at Hammersmith, they've tried to create what's called a gold zone, which is a zone which is completely, as free of COVID as one could hope for. And there are various screens, including swabbing of the staff, to be done. but I think that at the end of the day, the swabs are not reliable enough to be absolutely sure. And in most hospitals, there are still zones where the COVID is isolated, but there will be COVID in the non-isolated zones, but all of the normal things like the distancing, limiting the number of patients, etc., are in place. And I think patients have to be warned there is a small risk that you will catch COVID because of coming. This is why we're doing these telephone consultations, and we're trying to keep the number of face-to-face visits as low as possible.
And you brought in telephone consultation has become almost so normal. We've quickly moved on into virtual clinics. And we have a question now says, has diagnosis over the phone at all increased the number of misdiagnoses? And
well, this is the big question, but I think that I don't think so. I mean, if I know the patient, so they're a follow-up, I can deal with, I'd say, 95% of situations over the telephone. It might be a small change in medication. It might be just some general advice. I think if they're a new patient, what often happens is that I can speak to them and determine whether tests are necessary straight away or not, whether they can wait. And if tests are necessary, we have quite innovative techniques. For example, a Holter monitor, which is a monitor that's put on the patient's chest to monitor the heartbeat over 24 hours. This is currently being released the patient is being taught to put them on themselves, and there is a locker system, so the patient doesn't even come in to any contact. They have a code, they collect their monitor, they go home. Some of the tests for pacemakers are being done with the patient in their car, in the car park. So we are being quite innovative, but there are certain tests, such as an echocardiogram, which is an ultrasound of the heart, which does involve a very close contact. We will only do it if it's absolutely necessary.
Right, thank you. And you brought us to pacemaker. We have a few questions. Perhaps Dr. Barsamian, if you can take these questions. One of them is to monitor the pacemaker. Would you recommend using, as a general, using the wearable devices like Fitbit, or using the smartphone cardio apps to?
So first of all, the pacemaker itself is a great monitor. It has a memory, which is a very clever detection algorithms. So it can detect fast rhythms. It can detect even not only the rhythms, but some sophisticated devices like ICDs and cardiac resynchronization devices are also able to detect, say, the reduction of physical activity or increase in the fluid index in the lung that is suggestive of worsening heart failure and so on. So I would say monitoring wise, the pacemaker itself is the really best monitor. And there are two groups of devices that can be used by general public. I would say first group is devices that can give medical quality data, medical quality ECG that are approved by major organizations, say FDA in the United States. I can have, just for a demonstration, one of them that is promoted by Arrhythmia Alliance in UK for detection of atrial fibrillation, which is a very common problem in a population in a certain age especially. And this can give, together with smartphone, can give ECG and be diagnostic. So the patient can obtain the ECG, sent to, say, the arrhythmia specialist or the doctor who saw them in the clinic, and this can make a diagnosis of certain rhythms. On the other hand, Fitbit or any other general heart rate monitoring devices that do not show an electrocardiogram, but just show essentially a pulse rate detected by multiple technologies, some of them not approved, some of them not very reliable, some of them giving lots of noise and anxiety also. those are less reliable. The patients still, the number of patients wearing these devices is growing every day. People become more sporty, and older running people normally have those devices. And it is useful to hear what they say, to look at the recordings as well, sometimes correlating what the device showed and the symptom the patient had can give the answer. But unfortunately, if there is no an ECG recording function in that device, then the information we get from those devices are very limited.
All right, thank you. So there's another question which says that having a pacemaker is someone who has a pacemaker inserted a few years ago and they are otherwise in good health. And would this having a pacemaker predisposes them to have more complications if they had a COVID infection? And what are the signs or symptoms they should watch out for?
I would say the signs and symptoms are the same for as any other patient. So, cough, temperature, some vomiting, loss of sense of smell, etc. But the pacemaker itself, which is just a device, mechanical device, it doesn't get infected by the virus. There is no data showing that the virus can infect the device. But there are various conditions that necessitated putting a pacemaker, and some of them, which include heart failure, previous heart attacks, those are a group of patients who have structural heart disease, and by the virtue of having structural heart disease, they are more prone to developing complications if they are infected by COVID. On the other hand, if it was just a simple pacemaker, say you put in somebody who has got structurally normal heart, just slightly slow heart rhythm, nothing else, then those patients may be in the same category as anybody, the general public. So it will depend on the indications and the comorbidities that come with the pacemaker. It's a package, it's not just having a pacemaker or not having a pacemaker.
That's good, because we have another question which says someone who had a valve replacement surgery during the pandemic, and they are just concerned if they are at a higher risk of having complications. Would this would this put them into high risk?
A replacement of a pacemaker?
Not a pacemaker, but it's another question about having a procedure, or having, as you mentioned, there is some previous problems in the heart. For this particular case, they had a valve replacement and bypass surgery.
I would say everything we do in medicine and cardiology as well always includes balancing the risks and benefits. So if there is a life-threatening condition that requires a procedure, then most people would take the small risk of infection in the hospital and go ahead with the procedure, and most of them will do that successfully. On the other hand, if the indications are soft, if it can wait, if it can be postponed to a better time, to a more elective planning, then in those cases we could triage them, stratify the risk and triage them, and say, let's wait until a better time comes.
Okay. If when someone who had a pacemaker inserted this year and they still feel breathless and they are not sure whether this is to do with the pacemaker or it's to do with one of the symptom of COVID, how do you differentiate between this? What would you take on?
Shortness of breath, breathlessness is just an umbrella term that can mean multiple things, can mean respiratory infection, can mean heart failure, can mean anemia. So essentially everything that results in low delivery of oxygen to tissues or to the brain causes shortness of breath. So it would be hard to differentiate without hearing the story. So I would say if somebody became breathless, and it is good reason enough to call any medical practitioner, starting from GP is available, or the device clinic, because some of the staff working in device clinic are not only technicians by their training, but also they have got clinical knowledge and can advise whether that kind of breathlessness is something to worry and something that needs urgent investigations. But what I would recommend against is saying this is probably will pass away and let's stay home and not to speak to anybody. So somebody with medical training has to say whether that is worrisome and what needs to be done.
Well, thank you. So we move on to the questions related to diet and nutrition and how to keep a good, healthy health. So perhaps Arda would be able to take on this question. So now, one of the advice during the pandemic for people who had cough is to take lots of, drink lots of fluids, have hot water with honey and lemon. So the question is, how much is plenty of fluids? And would having sugar related to the honey cause diabetes?
So I guess that's a two-part question. First about fluid and then the sugar. So in terms of sugar, there's no real set amount that we know that would give us diabetes. And of course, diabetes is, there's a range of risk factors that would, that someone could develop diabetes, including genetic factors, age, other health conditions. So unfortunately, there's nothing that can be said in terms of sugar and diabetes in the honey. But what I would say is if you're including more sugar in your diet through honey, it might be worth considering reducing sugar in other areas of your diet. And in terms of fluid, so again, if you're a generally healthy individual, you have to drink quite a lot of water for it to be an excess. But generally, we advise for individuals to have kind of 6 to 8 glasses of fluids a day. And fluids can also include things like teas and coffees, fruit juices, but you'd obviously have to be a bit more careful with those because of the caffeine and the sugar content. But I guess a good indicator of whether you're well hydrated would be the color of your urine. So if it's a kind of light champagne colored yellow, you could be reassured that you're well hydrated.
All right, thank you. We're coming to an end to an hour session. Would the panel okay if we stay an additional 10-15 minutes? Okay, so Arda, the next question is that about salt intake. So we have a person who is an hypertensive but well-controlled blood pressure and engages in physical activities outdoors. And the question asks whether they should add on additional salt to their diet.
So I guess as a brief answer, no, I wouldn't be recommending for individuals to add extra salt to their diet. A lot of the foods we already have kind of hidden salt in them anyway. So even simple foods like bread, cereals, pasta sauces, soups, they all have salt in them anyway. So I wouldn't be recommending adding more salt. And as a guide, we kind of say to have no more than 6 grams of salt a day. So I guess that's something to bear in mind.
6 grams would be a tablespoon or?
About a teaspoon, yes, about a teaspoon of salt.
Right. And when we, therefore, what is your take on taking vitamin C and zinc supplements as a way of preventing the infection with the virus or the complications of the viral infection?
So there's no kind of set vitamin or mineral that has been said that would benefit the virus. If we're eating a generally balanced diet, we should be getting all we need in terms of vitamins and minerals. So there isn't anything that we've been advising specifically. I know that there's people who've been taking more vitamin C as a way of boosting their immune system, but there's nothing to say that will kind of specifically help with the virus that we're dealing with at the moment.
Brilliant, thank you, that's very clear. And they say the doctor's advice is to keep a healthy weight and to avoid overweight, have a healthy adult portion of food And what is healthy adult portion?
So I guess I don't know if anyone's heard of the Eat Well plate, but the Eat Well plate sort of represents what would be a balanced, healthy kind of diet. So we're looking at the larger portions of your meals being of the fruits and vegetables, and then the starchy carbohydrates, which are the things that give us energy. So those are things like bread, pasta, rice, potatoes. Then we're also wanting to include a protein source, so that could either be an animal protein like fish or chicken or meat, or a plant protein, which are the beans and the pulses. Then we're also looking to have some sort of dairy or dairy alternative, so your yogurts, cheese, milk. And then I guess the smallest portion of the diet, we're looking for that to be the oils and the spreads and the fats. So that should be comprising, that should comprise the smallest amount of the diet. And as a general kind of guide, we say for your plate to be kind of portioned up into thirds. So a third of it to be the kind of vegetables, the third to be the carbohydrates, and then the third to be
All right, thank you very much, Arda. So we move on in few more questions, which are more to do with the management of cardiovascular disease. And the question is, therefore, there was an issue about the ACE blood pressure medication, I think particularly the ACE inhibitors. And one of the question is that someone was advised to stop this medication and then advised to restart the medication. So we need a clear advice here, whether is it safe to take it? If Dr. Niger, or would you take on this question?
Yeah, so this is an interesting area that unfortunately there was a lot of flip-flopping back and forth on the advice. The reason there was this variance is that one of the ways the virus gets into the cells of the lungs is through an enzyme called ACE2, which is on the cell surface of lots of different endothelial cells. So it's in the lungs, it's in the vascular tissue, the arteries, and also within the heart. And in patients who take ACE inhibitor drugs, there will be a higher than average levels of ACE2, and therefore, theoretically, you have a higher chance of picking up the virus. There was one study that came out of China that suggested that those patients that were taking these drugs were at higher risk. However, all the subsequent studies didn't show that risk. And also, when they reviewed the data of that study from China, they had not done the correct statistical analysis. And when you corrected for the age of the patient, actually that risk went away. So the upshot of it has been that the European Society of Cardiology, as well as the British Society of Hypertension, and now also the American colleges, have recommended that you continue ACE inhibitors in those patients who are already on them. We're not likely to start the drugs de novo unless there's a real need. So if you've got a classical indication for an ACE inhibitor like heart failure, that's an absolute good indication. Now, for blood pressure, you can give another drug in that scenario. So what we've generally done is not take patients off them if they're already taking the drug. And if you're starting a new patient on a medication, you may choose to give a different drug if another one is suitable. But in general, we consider these drugs to be safe. And in fact, there has been some study data that suggests that they may actually have a protective role. I wouldn't read too much into that, but because I think much of the studies that have been coming out in the recent months are essentially rushed or pushing to get the information out there. And so what would traditionally take maybe a year or even 18 months to write a research paper, people are doing it now in a few weeks. So I take a lot of this with a slight pinch of salt, but I wouldn't immediately get worried about these drugs.
Thank you, that's really very helpful. So we know one of the complications of COVID-19 is developing blood clots. And if someone who has in the past an episode of a blood clot, would they be at high risk for developing another one? And if so, would they be eligible for the GECO, the new high-tech clot bursting device to prevent future events?
So all of our patients who have COVID-19 get admitted into hospital are given a blood thinning medication. And our treatments have evolved over a relatively short period of time, but almost every single patient gets some form of blood thinner, typically given by injection, to reduce their risk of developing clots. And in fact, one of the studies that we're running through Imperial College is to actively add in extra blood thinners in patients who have cardiac risk factors. This is a study that's, we've got the ball rolling very quickly, but now the pandemic is kind of slowing down, that it may not get to the answer we want, but certainly if there are further ways, we'll get more data. So certainly we are reducing the risk of clot by giving blood thinning medication.
What about the GECO, that we're having this device? NICE recommends it, but NICE recommends for hospitalized patients who cannot take other medication. But the question is whether this could be used as a way of a prevention at home.
So I'm not particularly familiar with that particular device. So is that in reference to people who've had pulmonary embolism and that treatment, or?
The question does not specify, but therefore I think someone who had in the past, whether it's a pulmonary embolism or DVT, we don't know here, but it's the question is, would you use them as a routine instead of using a blood thinning medication?
So we take all the preventative measures that normally work. So for example, compression stockings and mobilization of patients to reduce DVT and pulmonary embolism as a consequence of that. There are a number of other devices that are out there which essentially help patients mobilize in their bed space. Those are the principal ones. The other technologies that I'm aware of are principally to treat patients once they've developed clot. So and we do have a number of different ways of getting clot busting drug into patients through a device. These are not necessarily readily at hand in all hospitals, but we have access to them. We have to transfer the patient to another center to do that.
All right, thank you. So for people who have been hospitalized with COVID-19 and been discharged, and therefore how long they should be followed by the cardiologist, and what are the long-term implications? Are you seeing patients coming back, and what are the issues that you encounter for Dr. Gabrielian or Dr. Nijat?
I would say, I mean, the majority of these patients with the abnormal cardiac markers, the marker is almost a marker of their risk during the actual infection and during the hospital stay. So if we see a high marker, we know the patient is in danger in terms of their hospital stay. Most of them don't have very obvious cardiac dysfunction, but there are, when we do an echocardiogram, for example, it's a marker rather than a cardiac disease. But some patients develop this situation called myocarditis, where there's an inflammation of the heart muscle and there's a clinical reduction in the cardiac function. And those patients do need to be followed up, because some of them may develop a long-term cardiomyopathy. Others, though, and we think the majority, and certainly I've seen a few patients, have a dysfunction for just a short period, and then they make a full recovery. I think once they've made a full recovery, there's not so much need for long-term follow-up. So there'll be a proportion.
All right, thank you. Perhaps Dr. Bilalian would answer. There is this question about every session we see this question, and having comorbidities or other medical conditions would put someone at higher risk. For this, as we hear about them, but we need to differentiate between being higher risk for getting the viral infection versus higher risk of developing complications. Dr. Bilalian, you have any advice?
So the advice given by Public Health Organised regarding the high risk / vulnerable patient list was that they are higher risk of developing comorbidities. So therefore, those patients need to be shielding, and a lot of patients have been receiving letters saying that they need to shield because they are high risk. So it is really regarding comorbidities into developing complications, and rather than the risk of catching the virus. So you're more likely to catch it, but you're more likely to get a complication from it.
Excellent. This is been a question that comes every session. So very, very good to clarify. We have a couple of more questions before we give an end to the session, which are more of the general questions. So the first question is about the use of convalescent plasma. So the question is, at what stage of hospitalization do you think this convalescent plasma would be used, and would it be useful to prevent the heart complications? It's open to anyone who wants to have a dip.
I mean, I think this is a fairly undefined area. I mean, it's convalescent plasma is a sort of fairly old treatment for certain infections that was used maybe, 50 years ago for certain types of infection. But it's a question of whether it could be used, but it would be, I think it must be in the acute phase rather than, in other words, a treatment to combat the virus, and probably at a very early stage before the virus has actually had a chance to have a big effect. It's basically a way of helping the immune system to identify the virus and to kill it.
And we have to say there
are trials are underway, but we don't know if it's even effective. So I think it's something to be just used in a trial setting right now.
Exactly. Therefore, a trial is underway. We expect the UK ones by the end of June to end the study and see if it has any effect. And there was a recent study which has been in China, which had a randomized trial, which they terminated because there was no effect seen between the two arms. Okay. The last question is about steroid use in cytokine storm. And the question says that therefore it is used, steroids they use in the US, whereas it's not or discouraged in the UK. So what's your comment on this?
I think with a lot of these treatments, by the time that there is a cytokine storm, it's almost too late. What we're seeing certainly is that things like remdesivir and all these other antiviral agents and things have utility only if they're given very early in the infection. And once the cytokine storm kicks off, then it's almost a different pathology at that point, and the damage is caused by the inflammation within the body. Now, I'm not an intensive care doctor. I know that there is a huge amount of debate over the value of steroids, and I know it's not decided. So I can't comment on whether it's truly useful or not. But when you read in the various fights that occur across the Atlantic over one group that say it's good and versus other groups that say it's not so good, it's clearly that the data to govern these decisions is not very strong.
Very good, thank you. I don't see any questions coming from our listeners. Therefore, we tried to cover as much as possible, and I think we did comprehensive to the issues related to the heart, and saying therefore it's safe to go to the hospital, as therefore weighing the risk of having a condition and not going versus the risk of catching an infection. So I think we thank you for participating, and I will leave the floor to Dr. Seta to take on.
Well, I mean, there's nothing left for me. Thank you so much for all our panelists, Suk, Rafi, Sergey, Arda, and particular thanks to Nora for managing those questions. That was excellent. Thank you so much. And thank you for all our participants today. And we really appreciate your feedback. Please, to help us to improve our future webinar. I think you are aware that we are doing this sort of health or medical webinar bi-weekly now. And I'd like to just announce that next one, which will be on the 28th of June in 2 weeks' time, and that is quite interesting topic to the public, which several questions came to me about the impact of COVID-19 on dental services. And that will be delivered by Dr. Vahe Avanesian. He's independent dental surgeon at Harley Street, and Dr. Sarah Balian. She's educator and also dental surgeon, NHS dental surgeon at I think UCH, if I'm not wrong. I haven't got her full details yet. So I greatly encourage all to participate, please, and we look forward to see you all. And also I'd like to make a special thanks to Armand for his technical support, and to you all the participants. And thank you again. Thank you, Suk, for coming all that distance. Thank you, Rafi, Sergey, Arda, and Nora. And Christine, sorry, Christine, I forgot you.